So we're going to talk about the blood-brain barrier disruption thanks to the ultrasound, and specifically to the glioblastoma application, since it was the first application that could be feasible on a human. As you recognize, there is a glioblastoma in the left side here. It goes for surgery, and after surgery, you do the MR, and afterwards, the patient goes for the usual shoot protocol with radiotherapy and daily temozolomide plus 6 months of temozolomide. And as you know, also the survival is pretty low. And one of the main reasons is blood-brain barrier, which impedes most of the molecules actually to get into the brain. It's a physical, it's also a chemical barrier with selective transporter, efflux pump, and it's a metabolic barrier also. If you take the different drugs we're using every day for those type of pathologies, you see that nitrosourea is getting at 20% grossly, and same for temozolomide. And this is maybe why those drugs do have a certain amount of efficacy. On the other side, all the drugs are very low represented in the brain, so that don't cross the blood-brain barrier either because they are too big, or because they're not lipophilic or different conformational specificity. When I started to try to study the blood-brain barrier, I was very impressed to see that very poor data are known on blood-brain barrier crossing for different drugs. So there is some results in CSF, but it doesn't mean that it gets into the brain. It is of importance because you see that the efflux pump and the MDR and the PGP efflux pump are overexpressed, for example, in epilepsy, but also in blood, in the tumor and in the blood barrier tumor. For example, there is some study are studying the PGP expression in the different types of tumor, and those are increased. Many have been performed to circumvent this blood-brain barrier, mostly using transferrin insulin receptor technology, which is a drug is associated with a transporter that can stuck to the insulin or the transferrin receptor, although it doesn't work that much. There is also very nice development performed with the LPR antibody ligands, and there are some companies, so-called Geochem, that tried also vectors. Some are working more with a glutathione technology, but if we do a small resume of this, it helps the drug to get in, but it doesn't stop the efflux pump, so that the drug is in 20 minutes is taken out from the brain if ever it gets through. In addition, those receptors are mostly not brain specific, so that there is some peripheral secondary effect. And in addition, there is a functional down regulation of those receptors, so that there is an acquired resistance. And that's maybe why we have such difficulties, although those developments are fantastic, those difficulties to have efficacy with those technologies. As you know, if there is surgeon here, there is different way that have been, and neuro-oncologist way that have been explored to increase the drug delivery in the brain. High-dose chemotherapy, of course, with systemic adverse event, direct injection many years ago, osmotic action of different drugs, such as mannitol, for example, but it's very short operating duration. It's about 1 minute operating duration, and with systemic adverse event. Electroporation has been tried, but it's not specific to vessels. It affects the neurons also. Gliadel has been tried, but actually I'm not totally convinced about this, because only 5% of the drug contained in the wafer gets into the brain, and when it gets into the brain, it penetrates at 2 millimeters deep only. And after 48 hours, there is no drug anymore. There is only the substrate. Convection enhanced delivery, using, of course, the blood flow of the brain is maybe one of the most efficient, but the problem is the The duration, we cannot do it for many days. In 1956, so many years ago, Carpe showed that with ultrasound we can open the blood-brain barrier, but it was toxic to neurons. In 2001, Heininen from Toronto associated the ultrasound with echographic agent microbubble so that the acoustic pressure could be decreased and the vibration was concerning only the microbubbles and not the vessels and the neurons. And this vibration inside the vessels is inducing a blood-brain barrier opening. About 4 minutes of ultrasound can induce a blood-brain barrier opening for several hours, up to 8 hours. Here is an example of, you see, with gadolinium enhancement, blood-brain barrier opening, which repetitive action, that's one of my results in the dog, and to see that there is no attenuation over time of the blood-brain barrier. What happens actually? At the first very seconds, there is a micromechanical phenomenon with the opening of the tight junction, but those close very fast. What is interesting is the delayed functional phenomenon, which consists of a downregulation of cell adhesion molecule, upregulation of active transport proteins, such as scaveolin, which is increased. There is a non-specific endothelial transcytosis, so it's not receptor mediated. It's an active transcytosis. We don't know exactly why it occurs, but it occurs. We see it very well on microscopic, electronic microscopy. And very interesting, there is a localized downregulation of PGP expression, and this for 48 hours after the sonication. Sonication is a wording for ultrasound emission. So that the drug uptake is real, and it can concern heavy drugs such as antibodies, of course. And the size of the blood-brain barrier is dependent on both acoustic pressure and microbubbles. We did several experiments, of course, on primate with EEG, PET, evoked potential, MRI, and histology to be sure that it was non-toxic and that it was not inducing any neuronal disturbance. And there is also many study around the world using mostly external ultrasound. I will show you that my theory is to use implanted ultrasound, but the mechanisms are exactly the same, and many different teams are showing the non-toxicity of such a transient blood-brain barrier opening. If you see, for example, carboplatin, which is increased by a factor of 7, temozolomide is a little increased, but mostly also, as I said, it decreases the PGP efflux pump so that the concentration in the brain stays a little higher, but stays mostly longer. And of course, there is also many different articles by now showing that there is an uptake of the drug thanks to the blood-brain barrier opening due to ultrasound. In glioma models, we showed, of course, some prolonged survival with also an increase of concentration on the right side, down right, also a higher concentration of carboplatin inside the brain. The carboplatin is regularly injected intravenously as usual. There is no direct injection in the brain. It's a systemic drug and we are not the only one that showed that there is a prolonged survival in rat models. And for brain metastases, Alzheimer's disease, or gene therapy, or epilepsy, there is also some articles showing that there is some endogenous antibody uptake thanks to the blood-brain barrier opening. There is a plaque reduction of amyloid. There is also some antibodies for brain mets, but also there is some natural killer cell that gets better into the brain. So the immunity of the patient is getting into the surrounding brain. We're mostly concerned about the surrounding of the glioblastoma and not the glioblastoma itself, where there is a rupture of the blood-tumor barrier because you have a contrast enhancement. But we're most concerned about the recurrence of the disease and then the surrounding brain that does not take the contrast. So grossly, there is two technology now. Actually, there are three. I'm going to talk about the third afterwards. But it started by two technology. Either a technique with implanted ultrasound transducers inside the skull's thickness, taking advantage of the surgery so that instead of placing back the bone flap, you're replacing it by an ultrasound transducer bone flap, artificial bone flap. It allows for a large blood-brain barrier opening region, about 180 centimeter cubic, and it will show you that it allows some fast repetitive treatment over time. There is a much sophisticated technology, which is so-called high intensity focused ultrasound. And my friends at Inside Tech are doing a very great job by using 500 of transducer externally, using a stereotactic frame under the MR, and they can focus about 1 centimeter or 4 centimeter cubic area, which is pretty well appropriate for deep-seated lesions. Although the first technology here, the implanted low-intensity contact ultrasound LICU, is more adapted for superficial pathologies. When we did different experiment on mouse, rabbit, baboon, pigs, and dogs, we see that the more the animal was a higher intensity of ultrasound we should put in order to open the blood-brain barrier. It's amazing because it's somehow a correlation with the weight of the animal, which is, I don't think, no scientific substrate. So what I developed first is what we so-called Sono Cloud, which was implanted first on burr hole only. And the goal of this Sono Cloud is to be implanted either during debulking surgery or either during a biopsy procedure at the end. And so you close the skin normally, and the patient is coming back every month for his carboplatin, for example, session. And before or just after the carboplatin systemic injection, we are opening the blood-brain barrier. And this does take about 7 minutes to do so. So this first pilot trial was performed on 25 patients. And you see here an example of the blood-brain barrier opening. On the left side, it's the MRI performed 48 hours before the sonication. And on the right side, you see the contrast enhancement in the acoustic field, showing that, and we did a correlation between the intensity of the contrast enhancement and the drug concentration. Here is on a patient, a repetitive treatment. It was one every month, and you see that there is no attenuation over time. So there is no acquired resistance of this technique, which was a very important stuff to know, to be sure that it was still efficient. For example, this patient received 10 sessions, so 10 months. And you see that on these SWE images, susceptibility images, there is no petechiae at all induced by the blood-brain barrier opening. And for another patient, you see also there is no induced edema. This patient show even a reduced edema over time. And the corticoid didn't change, of course. There is no induced edema. For example, this patient, which was really big and not operatable, it was on this primary motor area. So we didn't want to invalidate the patient. So we put the device as a biopsy and device. And the patient had a pretty good actually survival. This is the same one. And you see that the edema also was decreased over time. We had some related adverse event, which is mostly two little seizures for about 1 minute after sonication for two patients. Exactly the patient that we couldn't perform surgery on, meaning that there is a huge mass effect And those patients had epilepsy before, of course, but just opening gave an additional little epilepsy for one time. It's a day of the sonication, but it lasts for only 2 minutes and stops spontaneously. One patient has a dexterity deficit also. We never know if it is really the tumor volume or the epilepsy. If you look at survival of those patients, the PFS was increased, and the overall survival also. So we are pretty happy of these results. And if you compare with different other technologies, it appears that it's pretty a good hint of possible efficacy for the future. Go forward. Next slide. Yeah, that of course the recurrence was not mostly, it did occur inside the acoustic field in one case. And in the other cases, always the recurrence occurred distantly to the acoustic field. Can you go back? Can you go back? Back. Can I go back? I don't see the.
In the bottom left corner, you'll see
Can
some arrows. Yeah, you should be able to do it right. Can you see?
No, I don't see it. I don't see it.
Your mouse is on it. Just
So we were concerned about this recurrence distant to the ultrasound field, meaning that maybe we're not covering sufficiently enough the tumor bed and the tumor surrounding tissue. For example, you take this patient here, you see on the right side that the sonication box is represented, and there is no flare progression inside this and no recurrence of the disease here. But more frontally, distant to the sonication, there is a progression of the flare signal. So our goal was to extend the sonication region by extending the number of transducers. So instead of placing one transducer in a burr hole, we are now replacing the total the skull bone flap by a titanium mesh with that includes 9 transducers. Here is, for example, an implantation of this device, and the patient, of course, the skin is closed, and when the patient comes back for his chemotherapy, the system is plugged transdermally to bring the energy to the device, because the device has no battery inside to be MR compatible, of course. And you see here an example of the devices on the left side here, on the right side of the patient. And you see the contrast enhancement cigars induced. You don't see the others because it's not on this slides, but you can see the large opening that goes even on the other side because you have CSF in the middle, so the ultrasound are not attenuated by the CSF. By now there is this is an overview of the different clinical trials existing with the SonoCloud, so the implanted technology, but there is also the Exablade, which is the external device. We're doing also a lot of clinical trial, and now a newcomer is from Taiwan is Navifuse, which is doing a system, external system, which is not performed under MRI, but guided by navigation. Here is exactly the 4 systems that does exist now. The InsightTech device from the external, requiring MRI, requiring shaving, requiring about 5 hours time under the MR to be able to perform a 4 centimeter cubic blood-brain barrier opening. There is a Navifuse system, which is about the same size efficacy, but which is a little more convenient for day-to-day clinical routine. And this is my option with the first SonoCloud 1, and now the 9 transducer that cover the entire region of the surgical bed. So the take-home message is ultrasound can induce a transient and safe blood-brain barrier opening. There is actually 4 devices available in the States and in Europe. The drug uptake is real, is with including antibodies and cells, and it can concern, of course, glioma, but also neurodegenerative disease. I am, for example, for neurosurgeon, it's a part of, but I'm now also working on Alzheimer's disease and lateral sclerosis disease. Voilà, merci beaucoup. I will take any question.
Alexandre, thank you so much. That was a phenomenal talk. I appreciate it so much. I think we're going to just keep moving on and do questions through the chat, unless anyone has any other suggestions. And Alexandre, you could actually probably respond individually to people if they wanted to contact you.
Okay, great.
Sound good? Merci beaucoup.
Thank you, Professor Carpentier.